Hello everyone, myself Dr. Akash Ganguly, and today the topic of my presentation is osteoradionecrosis. To begin with the contents, first I will talk about the definition, the incidence, classification, then the etiology, microbiology, clinical features, radiographic features, treatment protocol, the latest trends in the management, HBO therapy, the risk factors as well as the prevention, and finally the conclusion. Well, osteoradionecrosis is a debilitating disorder. Coming to the definition, an exposure of irradiated bone which fails to heal without intervention is the definition given by Marks in 1983. Again, Marks and Johnson in 1987 gave the following definition, that is, a chronic non-healing wound caused by hypoxia, hypocellularity, and hypovascularity of irradiated tissue. Van Merkestein in 1995 gave the following definition, that bone and soft tissue necrosis of 6 months duration, excluding radiation, induced periodontal breakdown. However, in Fonseca, it is defined by the exposed bone through the oral mucosa that persists for a period greater than 3 months in the radiated field. So an area of exposed bone that persists for 3 months when all other diagnoses have been excluded is the definition. And coming to the incidence, well, it is about 2 to 40% according to Odell and Uttam in an article in the Clinics of North America. Well, this varies in the literature ranging from 0.4 to 56%, and it is an approximately, we have seen that there is an approximately 20% decrease in the rate of this osteoradionecrosis from the earlier decades to 4 to 8% in the modern era, according to Chen and Wang. They concluded a retrospective study and reported that the incidence of 4.3% was found when a 10-year period study was done in 1023 patients in oral and oropharyngeal cancers using IMRT, that is intensity modulated radiation therapy. Well, mandible is at a particular risk due to the poor collateral blood supply, especially of the buccal cortex. The body and angle being affected approximately 83% and 43% respectively, and the most frequent ORN sites. And mandible is affected more than maxilla, as well as there is it has been found that radiation in the excess of 50 gray put the jaw at risk of radiation injury. And the interval between radiation therapy and the onset of ORN varies between 4 months and 20 years. The peak incidence is about 2 to 4 years. Coming to the classification, I will be describing few classifications, some clinical and some radiographical. Well, this was the one given by Marks in 1983, where he divided into stages. The first stage having exposed alveolar bone without pathological fracture that responds to HBO therapy. Second one is the disease that does not respond to HBO therapy and requires sequestrectomy and saucerization. The third one is full thickness bone damage or pathological fracture that usually requires complete resection and reconstruction with free tissue. Epstein et al. In 1987 gave the following clinical classification into 3 stages, that is resolved, chronic, persistent, and active, progressive. And they had subclassification having no pathological fracture and pathological fracture. So for the resolved stage, we have to go for follow-up for the prevention. And for stage 2 and 3, we have to go for local wound care, giving antiseptics or antibiotics and analgesics, and hyperbaric oxygen therapy if required. According to Notani et al. Classification, he divided into 3 grades, and the first grade was that ORN was confined to the alveolar bone. The second was that it was limited to the bone and a mandible above the level of the inferior alveolar canal. However, in the third grade, we had this definition that it extended below, the disease process extended below the level of the inferior alveolar canal, or skin fistula or pathological fracture could be seen. Another classification given by Andrew Lyons, that is into 4 stages. He gave a dimension of about 2.5 centimeter, and when it is less than this dimension, the length of the bone affected, that is less than 2.5, medical treatment was sorted. And when it was greater than 2.5 centimeter, we had two grades, 2 and 3. In the second grade, in the second stage, it was if it was asymptomatic, including pathological fracture or the inferior alveolar nerve involvement, medical treatment was given only. If it was confined and there was no dental sepsis or loose necrotic bone. However, when there was presence of loose necrotic bone, we went for debridement of this bone. And when the length of bone was 2.5 centimeter, or pathological fracture or inferior alveolar nerve involvement was there, or orocutaneous fistula, we went for reconstruction if the patient's general condition allowed so. So the final classification that I'll be describing here is by Carla Odell and Uttam Sinha. They graded it into 3 stages. The first one having superficial involvement only in the cortical bone exposed with minimal soft tissue ulceration. The majority of these lesions are solved with conservative management. And the second one is the localized involvement of mandible with exposed cortical or medullary bone, which are necrotic with possible orocutaneous fistula. So we go for conservative management followed by hyperbaric oxygen therapy. However, when there is the diffuse involvement of mandible, including the lower border and pathologic fracture with orocutaneous fistula, we have to go for resection and reconstruction. Coming to the etiopathology, well, there are 3 theories that I'll be discussing here. First, the trauma radiation infection by Mayer, the hypoxia, hypocellularity, and hypovascularity by Marx, the 3H principle rather, the fibroatrophic theory by Delaney. The first theory, that is the trauma radiation infection by Mayer in 1970, he suggested that the injury provided a portal or opening for the invasion of the oral microbial flora into the underlying irradiated bone. The microorganisms do not play a pivotal role in the pathophysiology. However, the role of trauma as the absolute initiating factor has been challenged. Coming to the radiation effects on the tissue, well, there is endothelial death, hyalinization, and thrombosis of vessels. The periosteum becomes fibrotic, and the bone osteoblasts and osteocytes become necrotic with thrombosis of the marrow spaces. The mucosa and skin also become fibrotic with marked diminished cellularity and vascularity of the connective tissue. On an organ level, it is composite tissue which is hypovascular, hypocellular, and hypoxic compared with non-irradiated tissue. The 3H principle by Marx goes as follows. The ability to replace the normal collagen loss or normal cellular loss is severely compromised here. The result can be a breakdown that is unrelated to the microorganism, but related to the degree of original radiation damage and the rate of normal or induced cell death and collagen lysis. The spontaneous osteoradionecrosis results when mucosal breakdown of the skin is due to tissue's inability to keep up with the cellular turnover and collagen synthesis. So when radiation affects the tissue, there's formation of this 3H principle, hypoxic, hypovascular, and hypocellular tissue. There's tissue breakdown, leading to chronic non-healing wounds. Now, the final theory given by Delanin, that is the fibroatrophic theory, we find that there are 3 distinct phases. The first prefibrotic phase, where there is change in the endothelial cells, together going on with the acute inflammatory response. The second one is the constitutive organized phase, where the abnormal fibroblastic activity predominates and there is disorganization of the extracellular matrix. And the late fibrotropic phase, when the attempted tissue remodeling occurs with the formation of fragile healed tissue that carries a serious inherent risk of late reactivated inflammation in the event of local injury. That may be trauma. So if we see this table, this flow chart rather, this radiation generates free radicals which may affect the bone cells like osteoblast, osteocyte, and osteoclast, leading to the irreversible damage of DNA with cross-linking or any disruption in this DNA, leading to the formation of fragile paucicellular tissues replaced by abnormal myofibroblasts. When the fibroblasts are affected, they differentiate to myofibroblasts, giving rise to interferons and PDGF. There is dysregulation of the collagen metabolism, fibrosis takes place, and this tissue is again generated. When the endothelial cells are affected, we may get microvascular necrosis, vascular thrombosis, leading to tissue loss. The microbiology. Well, the culture from these specimens, we may get Streptococci, Candida, as well as gram-negative organisms. If the skin is affected, we may get Staph aureus and Staph epidermidis. No organism is found in the deep bone. This is a very significant finding here. The radiation predisposes to actinomycotic infection since it provides a favorable environment for these to grow. Now, coming to the clinical features, well, as we can see here, if the exposed alveolar, if we find that there is exposed alveolar bone in the early stages, along with this finding, we may not get the symptoms, but later on, in the later stages, we may get a painful, debilitating, and a lesion that is frequently refractory to the treatment. So we may that this pain may be severe, deep, or boring pain, which may continue for weeks to months. There may be swelling if there is infection, and soft tissue abscess and persistently draining sinuses are present. Now, there may also be features of dysesthesia, halitosis, dysgeusia, fluid impaction, trismus, fetid odor, and pyrexia. In severe cases, there may be pathological fracture as well as fistulation into the oral mucosa. As we can see here, we have again a case of exposed alveolar bone. Now, this is an interesting case of a male patient, 60-year-old male patient who had oropharyngeal carcinoma. He had gone for radiation therapy, and after this, he developed this exposed alveolar bone. In the later slides, I will show you the OPG where we can find that there was a pathological fracture with respect to the mandible of this patient. This is an image showing the lesion affecting the skin of the patient with fistula formation. Then coming to the radiography, we may go for OPG, CT, or MRI to see the soft tissue. Well, there is little radiographic change that occurs early in the disease. The characteristic changes seen in osteomyelitis of non-irradiated bone. There is a formation of sequester or involucrum. OPG is the initial study of choice for this disorder or disease. It may show poorly demarcated sclerotic radiolucent areas intermixed with the lytic regions. The pathological fracture or sequester may be seen. The CT, however, is used to delineate the lesion to see the interruption in the cortical margins. It shows hyperdense changes on the bony architecture. This OPG shows pathological fracture with respect to the body of mandible. This is the OPG of that first patient that I had shown you, where there was an exposed alveolar bone when the patient of 60 years who had oropharyngeal carcinoma underwent radiation therapy. This is the initial stage where we can find that there has been a slight loss of the bone at the 7 region, lower 7 region, and the initial osteoradionecrotic changes are taking place. This is a moth-eaten interference that we can see affecting the body of the mandible and a typical feature of late-stage osteoradionecrosis. The histology is, however, not that significant with a microanatomic desert with reduced vascularity and presence of fibrotic tissue. The treatment, however, is to improve. If we divide it into conservative and surgical treatment, we may go for conservative approach by improving the oral hygiene, minimal surgical debridement, hyperbaric oxygen therapy, medical management using pentoxifylline, tocopherol, and surgical management includes sequestrectomy, saucerization, segmental resection, and free flap reconstruction. Now, according to this article by Andrew Lyons, there were 3 treatments that we provide. First, the medical treatment, the second, combined medical and surgical, and third, again, only the surgical aspect. For the patients needing extraction in the first medical treatment only, 1 week before the date of planned extraction, we give the patient pentoxifylline and tocopherol with the following doses. We continue it for 8 weeks. And if the ORN has been established, we continue it for 6 months. However, at 3 months, if there is any unresponsiveness, we add clodronate. And the combined medical and surgical approach, in this if we find large areas of sequestrum, we may go for pentoclo treatment, that is starting with pentoxifylline, tocopherol, and clodronate. 3 months before the planned sequestrectomy, then we go for sequestrectomy and consider extending antioxidants after sequestrectomy. For the surgical treatment, we may go for pathological fracture, which may require vascularized composite tissue transfer. Now we'll talk about the emerging trends. We will talk about the whole scope of treatment possible from this article by Meleka from the journal Head and Neck Cancer. Well, The first aspect is diet and lifestyle changes. That is, we go for smoking cessation, limiting the alcohol use, and optimizing the nutrition, as well as improve the periodontal health by using chlorhexidine or hydrogen peroxide mouth rinses. Coming to the pharmacological therapy, well, medical management alone is reserved for mildly symptomatic cases, and we may achieve full resolution. Steroids, however, they have been known to be a risk factor but may help in assisting in preventing this disease. And antibiotics can be used in prophylaxis as well as an adjunct in surgical interventions. The antioxidants, pentoxifylline, have no benefit in exposed bone but can be used with this vitamin E, that is tocopherol. And this regime that is called pentoclo consists of twice daily 400 milligram pentoxifylline, accounting for 800 milligram per day, then 1000 international unit of vitamin E or tocopherol, and once daily 600 milligram per day of chlordronate from Monday to Friday, that is 5 days a week. And the rest 2 days we go for 20 milligram prednisone, as well as an antibiotic like 1 gram ciprofloxacin. Now, the contraindication include any intolerance or allergy to the above-mentioned drugs, any recent cerebral hemorrhage, or retinal hemorrhage, pregnancy, renal impairment. Now, from this article, we have derived the function of the various constituents of pentoclo regime. Well, pentoxifylline and vitamin E combination is used to already reduce the fibrotic process, and the chlordronate is used to reduce the bone destruction by inhibiting the osteoclastic bone destruction. So in combination, they stimulate the healing process in the necrotic zone and reduce the radiation-induced fibrosis by synergistic action. The pentoxifylline is a vasodilator which increases the blood flow to the area of healing. Tocopherol scavenges oxygen radicals. Now coming to the pathophysiology and where these agents act is that pentoxifylline vitamin E acts at the radiation-induced fibrosis stage and chlordronate acts at the bone destruction stage. The main drug interactions include antiplatelet agents, heparin, ketorolac, NSAIDs. The side effects may be diarrhea, epigastralgia, asthenia, nausea, and insomnia. Non-surgical intervention include ultrasound therapy, in which it is an adjuvant low-intensity therapy given for 30 days that does not show reduction in the rate of ORN, but however, it has been used to halt the progression as well as assisting in the resolution of ORN once present. So it improves the vascularity and bone quality at the microscopic level, promote the angiogenesis, stimulate the osteoblast, induce cell proliferation, and improve oxygen delivery to the tissue. The standard procedure is 1 watt per centimeter square with 3 megahertz and pulse radiation of 1:4 with 15 minutes a day for 60 days. This is the main unit to which we add a transducer and a gel that is applied to the skin. Now coming to the hyperbaric oxygen therapy, it may be used alone or as an adjunct to surgery in the prevention of ORN with a history of radiation. So what is to be done here is that 100% oxygen is provided at a pressure of about 2 to 2.5 atmosphere for 60 to 120 minutes, once or twice a day for 30 to 60 sessions. Contraindication are in tumor recurrence or history of any complication with this therapy. Complications may include tumor recurrence, however, theoretical but not substantiated by evidence. So visual disturbances may also be there, barotrauma or oxygen toxicity. Now, this ORN prevention in those undergoing dental procedures. So the protocol of HBO before and after has to be adopted. A recent Cochrane study has, however, provided that the moderate quality evidence for increased likelihood to achieve mucosal coverage and prevent wound breakdown following surgery. And dental extraction prior to the anticipated radiotherapy has been known to increase the risk of ORN if it is done after the radiotherapy. Coming to HBO therapy, I'll describe it further that it is given again 5 days a week, and totaling to 30 or more dives, going with 10 more dives if required, and it induces the neovascularization and reverses the tissue hypoxia with a direct bacteriostatic effect. The contraindications include optic neuritis, immunosuppressive disorders, complications like eustachian tube blockade, tympanic membrane rupture, oxygen toxicity, ear sinus tooth pain, decompression sickness, pneumothorax, arterial gas embolism, deafness, changes in vision, nausea, fatigue, and claustrophobia. Coming to the Marks University of Miami protocol, in the stage 1, we go for 30 dives for giving the 100% oxygen for 90 minutes at the 2.4 atmospheric pressure. We examine the exposed bone. If there is a response present, we go for 10 more dives. So if there is no response, we may, in the first stage, we may go for stage 2, where we give surgery, we provide surgery and maintaining the inferior border, and 10 more dives of HBO therapy is given. However, we directly proceed for stage 3 if there is a presence of cutaneous fistula, pathological fracture, or resorption till the inferior border of the mandible. We go for stage 3 if the lesion is not resolving at the stage 2, or directly for these conditions. So we go for excision of non-viable bone, fixation of the mandibular segments, 10 dives of oxygen, reconstruction after 3 months, and then no further HBO would be required. So minor surgical interventions include pre-radiated extraction. The standard procedure is that the teeth with poor prognosis or next to the tumor should be removed, whereas teeth with asymptomatic periapical osteitis smaller than 3 mm should not be removed. The minimum time span between extraction and radiation is about 14 days to allow initial healing. Contraindications are central hemangioma, bleeding disorders, complication, bleeding, infection, and dry socket. Coming to the curettage and debridement, it is also known as sequestrectomy, alveolar sequestrectomy. Curettage and debridement is used for smaller defects with bone less than 1 centimeter, exposed bone, not requiring reconstruction and not also falling in the category of conservative management. In this, we debride the necrotic bone and soft tissue. The closure is done with is closed primarily, and this is performed under local anesthesia and not GA. So the complications may be prevented of general anesthesia. Coming to the contraindication, if any pathological fracture, orocutaneous fistula, radiographic evidence of resorption of the inferior border. The major surgical intervention include marginal mandibulectomy without reconstruction. The standard procedure includes 2 vertical as well as 1 horizontal. 2 vertical and 1 horizontal osteotomy are performed with an oscillating saw around the area of ORL. Extraction within the osteotomy sites are performed. The wound can be closed primarily with a full or split thickness skin graft. Complications include recurrence and wound dehiscence. Coming to the segmental reconstruction, resection with osteocutaneous reconstruction. Osteocutaneous free tissue transfer with fibular iliac crest or radial or scapular free flap. Well, out of these, fibular is the best. It is the main workhorse due to the consistent shape, the sufficient bone and pedicle length, the distant location to allow a two-team approach, and low donor site morbidity. The iliac crest has the advantage of abundant bone but suffer from the decreased blood supply. The scapular flap provides abundant tissue but the bone is thin, and the surgery may require patient repositioning. The radial flap offers abundant and flexible skin, but the amount of bone is again limited. The fibular flap, in this, the bone is vascularized by the common peroneal artery, and the bone segment is then often plated in place with the remaining mandible and soft tissue arranged to cover the mucosal defect. Contraindications are any lower limb vascular insufficiency or history of lower limb fracture for fibular flap. The complications may be fistula formation, hardware exposure, infections, flap failure, hematoma. So it is important to identify the extent of necrosis, so which can be very difficult, and the bone bleeding that we observe may not always correlate with the histologic findings. So this intraoperative use of tetracycline fluorescence can be done under the UV light to identify the vascularized bone, as the vital bone will demonstrate fluorescence. This is a case where the mandible has been resected, and after proper evaluation, the fibular flap could not be done in this patient. So they went for tibia. They went for reconstruction with tibia and this iliac crest graft. So recon plate was placed, and we can see the final CT after treatment. This is the CT showing the fibular flap reconstruction. This is the one with radial forearm, and this is the one with scapular. If we see, we can observe that the fibular one provides the best reconstruction out of these three. And one new treatment is this: we provide the 3D virtual guided resection, in which we take high resolution CTs to reconstruct a 3D model of the mandible to allow for preoperative surgical planning. Additionally, to incorporate information from the radiation. So screw holes can be planned outside this high dose fields. The contour models can be used to pre-bend the plates. This is the image showing the resection margin from the virtual model, and this helps the surgeon a lot. So this is another model. We can find that there's a pathological fracture, and this is the area where 60 grays of radiation has to be applied. In this again, this is the model. This is the application of the virtual CT. So what we do is that we find that this is the fibula. The fibula plating has been done. This is the area where 60 grays of radiation to the tumor site has been done, and this is the model now which will be used to pre-bend the plate. Now, the distraction osteogenesis, well, very few case reports have also used this method, and there's a corticotomy with an initial gap of 0 to 2 mm, and it is done 7 to 10 days at a latency period. The 7 to 10 days latency period advanced at a rate of 0.25 to 1 mm per day. The total amount of distraction ranges from 15 to 25 mm and takes roughly 100 to 200 days. Complications involve failure of non-vital new bone formation, necrosis of corticotomy segments, and contraindication when there is non-viable bone present. The emerging therapies include bone progenitors or autogenous bone grafting, in which cortical and medullary bone fragments are harvested with minimal invasive means alongside the newly exposed bone after debridement. The bone progenitors are covered with a mucosa, skin graft, or free flap. Contraindications include lack of any healthy bone. So rescue flaps, the new technique that has been the emerging trend rather for the reconstruction of ORN patients after the resection. So the necrotic bone is debrided until a healthy bleeding bone is encountered. Anterolateral thigh fasciolateral flap is harvested based on the circumflex femoral vascular system. So using a minimal access approach, the harvested tissue is anastomosed to the native vessels in the face or neck to establish the blood supply. Once revascularized at the recipient side, the fascia lateral flap is wrapped around the bony defect and secured in place. This technique can be used with or without autogenous bone grafting, but is usually reserved for patients with extensive bone loss. Contraindication of pathological fracture, active infection. For 50% of affected bone, or less than 1 centimeter of the remaining inferior border is remaining of the mandible. Complication of persistent progressive ORN or infection resulting in pathological fracture, trismus due to scar band formation, seroma, hematoma, free tissue flap failure. So it is important to note that this rescue flap does not preclude the need for any further reconstructive procedure if the ORN is not arrested. So we may have to go for other techniques if this has failed. It is a low morbidity procedure, so the hospital stay has been reduced to 1 to 2 weeks. This is an image showing the fascia lata flap or the rescue flap being used, and after the debridement, this flap being placed, and this is the 6-month post-op period recovery photograph showing good healing. Finally, I will describe the risk factors and the prevention. The risk factors are that the radiation dose, the most important factor, when it is greater than 60 gray radiation, the majority of cases have been reported. And those who receive brachytherapy are also at an increased risk. Some important factors are that when the tongue, floor of the mouth, alveolar ridge, retromolar triangle have been involved, there is a risk. Cancer at stage 3 or 4 or prior surgery if it is done, periodontal disease. Using this article by Kubota et al. To talk about the risk factors. In this, they found that 46 out of 616 patients developed ORN, and it was found that the 60 gray radiation fraction had the incidence of about greater than 14% when oropharyngeal or oral cancer was present, the primary tumor being present in these two areas, and when there was post-radiotherapy tooth extraction and receiving concurrent chemotherapy. So the risk factors were highest in these conditions. So the possible risk factors are poor dental health, pre-radiation therapy surgery, having segmental mandibulectomy greater than those that do not, and those who did not receive marginal or those who did not receive the segmental mandibulectomy, or those who received the marginal or hemimandibulectomy. Chemotherapy, when used in conjunction with radiotherapy, also has an increased risk according to Rotter et al. So in this study, by Kubota et al., the pre-treatment extraction was performed to avoid the risk. So effort should be made towards the prevention of post-radiotherapy dental extractions. Preventive measures, well, prevention is the most crucial aspect of management. Main goal is to avoid the need for tooth extraction during or following the radiation. And teeth in the area to receive the radiation should be extracted when they are extensively decayed or infected, partially impacted, or have a pocket depth greater than 5 mm. Following extraction, 2 to 3 weeks of healing is advised before the initiation of radiation, and it can be done after the radiotherapy within 4 months following the completion of this radiotherapy, as tissue repair and healing is going on, and within 5 to 6 months, the progressive fibrosis and loss of vascularity that lead to ORN have begun. So an important factor is patient education using fluoride, high fluoride toothpaste. Edentulous patients are monitored for breakdown of any tissue below the dentures. Advances in radiotherapy, having RT and 3D conformal radiation therapy, allow for higher doses of radiation with less damage to surrounding tissues, and less damage to the normal tissue in the mandible will reduce the risk of OR. The prevention is that those who receive previous tumoricidal head and neck radiation should receive prophylactic HBO therapy prior to the oral surgical procedure. So they should require 20 days of HBO therapy before and 10 days post-operatively. The Marx 1983 criteria for success is the absence of pain, mandibular salvage or reconstruction, restoration of mandibular function, and survival of the overlying oral mucosa. Finally, I would like to conclude by saying that ORN is best defined as a slow healing radiation-induced ischemic necrosis of bone with the associated soft tissue necrosis to variable extent in the absence of any local primate tumor, necrosis, recurrence, or metastatic disease that may or may not be superinfected accompanied by fistulation and in pathological fracture resolved without surgery, HB, or both. These are my references. Thank you so much.